Yeah? All right, cool. We're gonna talk about that. And then Gemma's gonna start talking about rhythms. And then when we do lab, we're gonna do some CPR, we're gonna do some beginning ACLS, okay? Because you guys should all be good at CPR, right? But now you've got to think like a medic. And there's different logistics when it comes to doing a code when you're a medic, because you've got to think of everything. If you have a good partner, that makes life easy, but that does not always happen, okay? So you have to make sure certain things happen, whether it be checking the rhythm first, doing the airway, starting the IV, giving the meds, knowing when you gave the meds, all of those things, right? So we're going to practice the logistics of that in the beginning of ACLS, right? Because it's a groove that you have to kind of get into and think like. Because now you probably think, okay, AED, pushy, pushy, blowy, blowy, right? Well, now you got to add in some other things, right? So we're going to start practicing that. So you will have a quiz next week, right? And it will be on the atrial rhythms. Okay? And we'll talk about those tonight. All right. So on this sheet, we're pretty much all familiar with coronary causes of a heart attack, right? When you think of a myocardial infarction, what do you think of?
Ischemia of the cardiac muscle.
Why? Like what's causing it?
Clot.
Right, so it's usually a clot that we think of, right? Well, there are very many different things that can cause it. So one of the things, especially if drugs are involved, cocaine in particular, is you can get a coronary spasm. So there's no clot, but since the coronary arteries are spasming, your heart gets ischemic, and you can actually have tissue damage, which is an MI. Okay? Can somebody go into cardiac arrest from that?
Yeah.
Absolutely. Okay. What else? So you can have something called SCAD. Anybody ever hear of SCAD, especially in relation to women?
Never heard it a day in my life.
Okay. Well, spontaneous coronary artery dissection. It tends to happen in women, especially younger women, and they may have some underlying tissue disease that can lead to it. So, not every chest pain is straightforward clot, is the point, right? So, some of the non-coronary cardiac causes, somebody gets hit in the chest. It can cause an RNT, right? Commotio cordis hits right at the wrong time, puts somebody into VFib. Right. He's the most recent example, Damar
That's a
Hamlin.
very shocking situation.
So, if there's an AED right there, you can defibrillate them and most likely get them out of that rhythm. Okay? Because it's not caused by a clot or, heart myocardial damage. As long as you get that electricity to, if you think about what's defibrillation, it's a Control-Alt-Delete of your heart, right? It stops it, and then it allows it to restart again in a normal rhythm, right? So if somebody gets immediate defibrillation or almost immediate defibrillation, the chances of saving them are really high, okay? That's one of the reasons why there are AEDs in schools, because in general, younger people don't have heart attacks and MIs from clots. Not that it can't happen, but the most likely cause is a hit to the chest. It could be a myocarditis. So what does itis mean? Inflammation, right? So that can cause a cardiac arrest. Super strenuous exercise can cause somebody to go into cardiac arrest. Anybody do standbys for marathons?
That hill no stairs, man.
True.
The hill may take you out, yeah, but usually at every big race where there are thousands of people, somebody goes down, right? And you think, wow, why would that happen? Well, not everybody that trains for marathon trains appropriately for marathons, and they could be really exerting themselves. It also depends on what? What do you think? Temperature, right? So what's the air temperature? What's the humidity? What's the course like? Is it flat? Are there hills? Right? So those are some of the things. Takotsubo cardiomyopathy.
Taco?
Anybody hear of that?
Also known as broken heart syndrome.
Oh, I heard of it.
Yep. So that's what that is, right? Would you like to explain that?
Sure. Fun fact though, does anybody know why it's called Takotsubo?
Named after a person?
No, it's actually named after the Japanese like nets that they catch octopus in. So it's like an octopus net, and it's just what the heart looks like. It looks like an octopus net. It's a part of dilated cardiomyopathy after repeated stress or high stress. So it's more commonly known as broken heart syndrome because after the emotional loss of a loved one, you have increased cortisol, and that can cause a cardiomyopathy, which can cause ischemia to the heart and elevated troponin and everything that comes with that. I've actually seen a case of it, which is pretty.
Of course, I've asked her probably. Yeah.
The older.
Believe it or not, you see a lot of Vassar. There's a lot of, you see all the things that you don't think you would see in the city of Poughkeepsie, but because it's the city and the rural and across the bridge and all that stuff, you get to see a lot of different things. All right, transplant rejection. That's bad, right? Because they were sick enough to need a heart to begin with, and then they got one, and then their body's like, nope. So those are really, really sick people. They're going to want to go, if they know what's going on, they're going to want to go directly to where they had their transplant. Depending on how sick they are, we most likely cannot do that. We need to go to the closest hospital and then stabilize them and then transplant. So it all depends. Okay. All right, so non-cardiac causes. When we have that person having severe respiratory distress, say from a pulmonary embolism or whatever, the hypoxia, that can cause ischemia in the heart and could cause them to actually have a myocardial infarction. Okay? So you can get it from somebody having a severe anaphylactic reaction, and because what happens? Their blood pressure drops, they're having respiratory distress, and their body is like, oh shit, I'm dying, right? They get tachycardic, and then what do we give them? Epi. So their heart's stressed to begin with, and here we are giving them epi, which is going to fix their anaphylactic reaction, but if they have underlying cardiac problems, they might code. It has happened. There's a guy in Wappingers that has coded and has had 2 severe anaphylactic reactions. This is the weirdest stuff, okay? So this guy, probably 4 years ago now, was outside. He's very allergic to bees. He's 70-something years old. Weed whacking. Gets stung by a bee. Goes down. He's having an anaphylactic reaction. The medic gets there, gives him epi, and he codes. Got him back. All right. He ended up having a couple stents after that. 2 years later to the day, he's out doing yard work again, gets stung again. I get there, as I'm walking in, the wife says to me, oh, the last time he got epi, he coded. And the fire department had told me on the way in also that they were bagging him. I'm like, fantastic, right? So he was unconscious, they were bagging him, he had no radial pulses, he had taken 1 EpiPen, the fire department helped him with 1 EpiPen. I grabbed his other one because that was the fastest thing to do and gave him the second one. I had him on the monitor and I'm like kind of looking at the monitor like, please don't die, please don't die, please don't die. Well, he did not die because he had those stents to take care of the underlying cardiac disease that he had. So this time he did not code. And he got much better with fluids, epi, Benadryl, and steroids. Okay? So I asked him to please stop doing yard work. Because I don't know that he would survive the third time. All right. What else? End-stage renal failure. We have so many more patients now than we used to that are on dialysis. Dialysis is not an easy thing for your body. It's very hard on the body, right? And they go and they have all this water and fluid and electrolytes shift. Do you think you feel good after that? No, right? And what if they screw up? That ever happened?
Me and Kyle Shook just did one 3 hours ago.
It regularly happens, okay? So these people are not healthy to begin with, right? They've got multiple comorbidities. What are some of the comorbidities they most likely have? Okay, definitely anemia, hypertension. What else? Diabetes, right? So diabetes and the hypertension are the things that probably are causing them to have been in the renal failure to begin with, okay? But so they've got lots of underlying things. So then 3 times a week we take them and we hook them up to this thing and we shift their fluids all around, right? So things happen. What happens when, they have a cold and they didn't feel like going to dialysis?
And we see them the next day.
Yeah. So we generally see them shortly after because they don't have the toxins and the potassium and all that stuff taken out of their bloodstream. So they get hyperkalemic. Too much potassium will kill you. It will stop your heart. Okay. Before that happens, we generally see some signs and symptoms, right? So what do you think we usually get called for?
Difficulty breathing.
Yes, difficulty breathing. Why? Because they're probably acidotic and their body's trying to compensate, right? So they're breathing at 30 a minute. We listen to their lungs and they're clear. And they're diabetic and they miss their dialysis. So your brain should go into, I think they might be hyperkalemic. So we put them on high flow oxygen, right? We take their vitals. They probably need some fluid, even though they didn't get fluid taken off, but the fluid's in the wrong place, right? And their blood pressure is probably in the toilet. And you do their 12 lead. So when we get into 12 leads, you will see that they will have peaked T waves. Bad squiggles. So if you look at the T wave and it's pointy and it looks like it would be very uncomfortable to sit on, that's hyperkalemia. Okay? That's how I like to remember that. What will also happen is their QRS complex will get wider and wider. So what happens is if you think about your EKG here as a string, you're basically pulling both ends of the string and this is getting wider. What happens as you pull that end of the string? Asystole, right? They'll start to get bradycardic and then they will go asystolic and you'll be like. So, I really like the LifePak 15s or giving myself the 12s because it would spit out a new 12 lead if something changed. Results don't do that, okay? So it kind of alerts you to, their QRS got wider. Something has changed in their 12 lead, okay? So you have to watch them very closely because they can change in a 15-minute transport to, up Route 9. They can start to be in a bad place and you may have to give them some calcium to stabilize their cardiac muscle, okay? Is that going to fix them? No, but it's going to help keep them alive until they can get some insulin, some glucose, possibly dialysis, and they may also, you can use albuterol. Wow. Anybody know why? They're not using. It takes the potassium and it that shoves it back in the cell. Because right now, if they're hypokalemic, there's too much potassium in their bloodstream. Okay? So albuterol helps move it into the cells. It's a temporary fix, but it will keep them alive until they can get the insulin and the glucose and probably the bicarb that they may need and the dialysis they need. So it's kind of an intermediary step to keep them alive so they don't code on you. Because anytime somebody codes, it's much harder to get them back. If you can prevent them from dying, that's the way to go. Okay? All right. So, sepsis. So you have a patient that is severely septic. How do they present? Okay. Are they initially bradycardic? Probably not. It depends on how far along they are in their shock state, right? So their blood pressure's in the toilet. They're probably initially tachycardic. Yep. They most likely they have a slight fever depending on their age. Younger people tend to spike higher fevers than older people. They might also be hypotensive and hypothermic. Yeah, it's called cold sepsis, right? So when you're not perfusing well, there's organs that really like perfusion in our body. Your heart, your brain, and your kidneys. If it's not getting it, it's cause damage to those organs. Okay? So that hypotension is not a good thing. So what do we do for sepsis? Fluids, for one. What else? What'd you say? You sirens to the hospital, maybe. Okay, so norepinephrine, suppressors to keep their blood pressure enough so that they're perfusing. Okay, and there are some systems out there using broad spectrum antibiotics. Because the studies show the sooner you get antibiotics, the more likely you are to survive. Now, do nursing homes call us when the patients first present as septic? Because they don't freaking notice, right? So I call it suddenly septic. We get there, the person's been sick for probably a couple days before they notice, and they're like, oh, they just arrived it. So we tend to get them on the worst side of things, right? They're confused, they may have a temp, they're hypotensive, they may be hypothermic. So intervention is key. And by the time they go into septic shock, half of those people die. Right? They also probably, if they're older, if they're in a nursing home, they have comorbidities. Right? So that makes it harder for them to mount a defense. The older you get, the worse your immune system gets. Right? You're on, let's say they're on beta blockers. Can they get as tachycardic that somebody is not on beta blockers? No. Right? So if you're in severe shock and you're 20 years old, heart rate can get up to 130, 140. Right? You're on beta blockers, maybe you got 90. And the problem is that not everybody recognizes that. Okay? So for us, we have to look at the med list and be like, oh, their heart rate's 90. Their pulse oxygen is also 89. They're altered. And they're not perfusing. They're cool, pale, and diaphoretic. They're in shock. Right? It doesn't matter that their heart rate is just 90. That's really tachycardic for them because they live at 60. Right? And their body can't compensate anymore. Does that make sense? I see people miss that a lot, so that's why I make sure I keep that up. Because they're like, oh, the heart rate's 90. Well, yeah, but what about the rest of it? All right. And, of course, stroke. How will a stroke cause an MI? Okay, yeah, they already got clots going on, so that's one way. What else? Okay, and what would happen then?
That's pretty good enough.
Okay, so
there's an infection that's in the brain that's affecting the vital signs that come from the medulla, yes, that could be a problem because then they may be not getting perfusion in their heart, which could cause heart attack, right? What about, let's say they have a bleed and their pressure's through the roof? Can that cause cardiac damage? Sure. Right? Because the body is really smart and tries to compensate for things. So it's trying to perfuse the brain, so that's when the blood pressure goes up. That's why you don't fix that. We used to fix it, and it was a bad thing. Okay? When I first became a medic, we had this little pill, it was Procardia, which is the same category as Cardizem, okay? And we'd have to poke a hole in it with an 18-gauge needle and squirt it under their tongue to bring their, when they had hypertensive crises, okay? But it was also in the protocol for stroke. But what happens is you're taking away the body's compensation for perfusing the brain. So that's why we don't do that anymore. Okay? They may do it in the hospital in that they can do it in the drip, that's, and they can control it, but they still don't lower the blood pressure a lot. Okay? They keep it in a certain range based on what the evidence shows, but it's still perfusing the brain. So you don't want to drop that pressure because you want to perfuse the brain. Otherwise, what happens? You end up in the Northeast Center, right? So that's bad. All right. Any questions about this stuff? All right. So lots of different reasons. Between 7 and 7:30. Okay. Okay. Alright, so there's lots of different things that can cause cardiac damage, so keep that in mind. Alright, it's not just blood clots. So, alright. Jen, any pictures?
I don't know if anybody else is a visual learner. This helps me. Okay. You guys can take pictures of your stuff. Yeah.
Are you close to being memorized?
Yes.
Okay, so you ready to start?
Yeah.
15 seconds. I'll talk some other things.
Do you want to use your PowerPoint?
No, I want you to do whatever you want. I will put my PowerPoint up on the right. I'm going to say right anyway because it used to be one Blackboard and there's a source that's pretty good. All right, does anybody want some other slides? You can go grab it real quick.
Is that how we want to work? aka your bundle of his, but we're not naming things after old white men anymore. And then left bundle branch, right bundle branch. Make sense?
All right. Take it away, Dr. O'Connell.
All right. So before we get into like all of this, we'll first talk about like myocardial cells and the properties of myocardial cells. Did you guys learn about the properties of the myocardial cells? Automaticity, contractility. Yes. So you have automaticity, the ability of myocardial cells to produce an electrical impulse on their own. It's spontaneous. You have excitability, so the cells can respond to the electrical stimulus. Conductivity, the cells can then transmit that electrical impulse to other cells. And contractility. So every cell in the heart can do all four of those. And there are two types of heart cells if you're going to separate them out. You have the pacemaker cells, and then you have our contracting cells or our conducting and contracting cells. So does anybody know where the electrical impulse starts in the heart? Yeah. So I have it down up here. This is your SA node. So it's kind of like right at the top of your right atrium, right? That's where the blood first enters the heart. Then it goes to the AV node, which is right here. And it's aptly named the AV node because it's the atrioventricular node, so it sits right between the atria and the ventricles. And then your electrical impulse goes to the atrioventricular bundle, aka the bundle of His, which kind of sits right at the interventricular septum and then splits into its left and right bundle branches. Does that make sense? As it goes down to the inferior ends of the ventricles, you get your Purkinje fibers. Does anybody know where the SA node, what its like heart rate is? The rate of the SA node? 60 to 100, yeah. So SA, 60 to 100. Does anybody know what the AV node is? Yeah. 40 to 60. And then as you keep going down, it keeps getting less and less.
So somebody has a heart rate of 30. Where the heart do you think that's coming from? The ventricles. Yeah, the ventricles. Yep. And you get a wide QRS. And you better be stopping this guy now. Yeah. Or do it with you.
Anybody know what the Purkinje fiber intrinsic rate is? 20 to 40. That's what I never really cared to know about because if the only electrical impulse is coming from the Purkinje fiber, it's like my patient's dead. They're basically dead.
Well, soon.
Yeah, they're not dead. Does anybody know why it gradually gets slower? I don't want to take a while to guess why it gradually gets slower.
Because the electrical conductivity sent from the brain to the heart saying it needs to be less. So it's like it's further down the capabilities.
Yeah, it takes time to send these impulses, so you lose time between each of these steps. It's also kind of the safety of the heart, right? Because if your SA node is beating really fast, you have to have time for the ventricle to actually fill once it relaxes. So the AV node is kind of the like pacemaker of the SA node, if that makes sense. It keeps it in check. And then the Purkinje fibers keep the AV node in check if it gets around. Any questions?
So we're talking about safety net. So what's really cool is that if your SA node stops working, those cells kind of look up and say, hey, we're not getting an impulse. We better be. Right? If that happens in the atrium, it can happen in different spots. What do you think that's called? They do, yes, because it's coming from different cells each time, right? So that's why you just have the regular zero. Okay? And then if nothing's coming from the atrium, and you're at the junction, the AV junction, it looks up and says, hey, something's going down. You gotta do. Right? So then you get your 40 to 60 heartbeat. And then if nothing's working in the junction, the ventricles are like, we're the last, the last frontier. We gotta do. It's pretty ingenious how it works. Yeah. So then if you feel rhythm, these are all video pieces.
Anybody know what I'm labeling up here? Does everybody have like their favorite mnemonic or something? Smoke over fire and what? Ooh, I've never heard that one before. What's a good one? Anybody else have a different one?
Salt, pepper, ketchup, guacamole.
Guacamole. That's a traitor green. Yeah, I use like white on the right and then smoke over fire, and then by default, green just kind of is where it is. Does anybody know what the green lead is? Ground. So I also say green, ground. So this one actually doesn't produce a deflection on your EKG itself. So for your EKG, you have, this is my cheat sheet of like how to read an EKG. So if you have depolarization towards the lead, that's my little symbol for a lead, then you have an upward deflection on your EKG. Does that make sense? If you have depolarization away from your lead, then you have downward deflection on your EKG. And then the opposite is true of repolarization, right? Because you have depolarization where the cell gets less polarized, and the resting, does anybody know the resting voltage of a myocardial cell? It's like negative 70, negative 90. And then repolarization, so you're getting more polarized towards the lead is a downward deflection, and then repolarization away from the lead is an upward deflection. Does that make sense? Kind of, sort of?
You want to show them on your little stick figure?
On my little stick figure? I love stick figures. I also can't draw. So this is my heart, right? If I have depolarization, which normal depolarization goes from this to this, right? The heart sits kind of like sideways, diagonally. So positive deflection towards this lead. Does that make sense? Positive depolarization, right? Because we're coming towards this lead. So that would show up as a upward bump, upward squiggle. Where you see squiggles now.
I told you you'd get these squiggles.
And then as you come to the ventricles, right, and you have to come back around to get to these sides of the ventricles, and you're going away from this lead, downward deflection. Does that make sense? Yeah. Okay. So then here I have written out
Figure for the win.
stick figures, always, honestly, pictures for the win. All of med school is just my notebooks full of pictures. Or like, I swear. So I have my P, Q, R, S, T, my J point, but we can get to that another time. And I have everything written out as far as what all of these mean. So first we have the SA node. The SA node sends out its electrical impulse, which creates a P wave, because my atria is depolarizing. As my atria depolarizes, then it starts to contract, right? So depolarization of the atria, contraction starts. We get to the AV node, which is here, right before my QRS. And then my QRS is ventricular depolarization and contraction. It's also atrial repolarization, but that gets buried in the ventricular depolarization, if that makes sense. And if you think about it, where does the atria need to pump blood? To the ventricles. ventricles need to pump blood? The lungs and the body. So you need a way higher amplitude, a way higher voltage of your electrical impulse to create enough contraction to pump to the whole body as compared to the ventricles, which is like an inch away. So that's why it gets buried in the QRS. And then you have your T, which is your ventricular repolarization. I also have labeled here your isoelectric line. So your positive deflections, your negative deflections. Towards the lead, away from the lead. And each lead has its own strip, right? So anything going towards the lead is going to be above the isoelectric line, away from the lead, below. As long as we're talking about depolarization. That switches when we talk about repolarization, right? Questions? When you're talking about depolarization, repolarization, yeah, the opposite. Hence my little teaching. So, what's the purpose of this? Like, why do we care about the squiggles at all? We care to see what the electrical picture of the heart is. We care to see what the heart is doing electrically. We can identify the heart rate through this, also the rhythm through this. We can also see if there's any prior damage to myocardial cells on an EKG. We can also see if there's any current ischemia going on. We can see if any of the pathways are messed up. I'm sure you all have had like a readout where you're like any medic that you've shadowed has a readout and it's like left bundle branch block. And you're like, I don't know what that means, right? But it means that there's some aberration or interruption in this part of the pathway, so that when you have a lead sitting over here, and you have your aberrant conductivity going towards that lead, it'll show up here. Does that make sense? We're not going to get into bundle branch blocks yet, but we will eventually. And they're kind of my favorite. I do kind of like a bundle branch block. William Morrow. Tomorrow? William Morrow. Oh, William Morrow. Oh, yes. We'll learn about that. So we have our leads on our little stick person, and the fourth cable, or the green cable, is your ground cable. So that doesn't contribute. Can anybody think, or has anybody seen anything that could cause what should be our picture to not show up right, correctly?
Hair, sweat,
Dirt, all of the things, yeah.
put them on walls, put them on backwards.
Always carry extra stickers because you might need to give somebody a little wax job. And then re-put the sticker on. Also, just switching your leads. Lefts and rights are hard. I don't know about anybody else. Lefts and rights are hard. And patient movement too, because movement can disrupt an electrical impulse, especially with your limb leads. If your limb leads are now up here, where they should be down here, then your conductivity towards the lead is no longer towards the lead.
What do you think happened to a patient that had Parkinson's? A lot of artifacts, and good luck figuring out what the rhythm is, because if they've got the tremor going on, it's nearly impossible to get a good.
It's rough. Yeah, it's rough. Do you have like EKG paper, or do they have a handout of EKG paper?
No. I'll go grab some.
Okay. So once you know that you're going to have leads on your EKG, 3, 4, or 12 of them. So you'll have 3, 4, or 12 of these rhythm strips, because they're kind of their own rhythm strip. And it's plotted on EKG paper, which is standardized because all of the boxes mean something as far as time goes. And I have it on my laptop, but I don't know if you guys will be able to see it. A rhythm strip on standard EKG paper is how many seconds does anyone know? A snapshot in 6 seconds. Sometimes it's 10 seconds, depending on like the length of your paper. each small square, like the tiniest square, is like 0.04 seconds. Super, super tiny. And then 5 squares is 0.2 seconds, right? 0.04 times 5. And then 5 larger boxes is 1 second. And then 15 larger boxes is 3 seconds. I don't know if you guys can see this, but we'll point it out in terms of paper in here. And then, so if your horizontal axis is time, right? Each little box represents a length of time. Then what's your vertical axis? Amplitude, yeah. So the strength of the impulse. And your isoelectric line is your baseline where there's no electricity detected or the electricity is canceling out to be at that isoelectric line. Does that make sense? So this is like 0 millivolts. If you wanted to put a number. So then each of the components of the EKG, we said that the P wave is the impulse from the SA node and depolarization of the atria. I drew one up here, right? But what does a P wave usually look like? A speed bump, yeah. It shouldn't be high in amplitude, right? Because we said that the atria depolarizing shouldn't have that much of an amplitude because it doesn't need to contract that much to get the blood from the atria to ventricles. It should be upright, round. Duration should be like 0.06 to 0.1 second. It should be short, right? The electricity doesn't have that far to travel, so it should be small. And the amplitude, I don't know if you guys can test it on that, but it's like 0.5 to 2.5 millimeters, which corresponds to a specific number of millivolts. But also the So a bundle branch doesn't have anything to do with the P because we're just talking about the atria. And the time that you're talking about like normal is like the PR interval. So the time from your P to your R. Does that make sense? And then the length of your QRS should be a specific for normal. But just the P wave itself, just the upward deflection here. What did I say? 0.2. 0.02. Or 0.06 to 0.1. What are these little boxes? 0.04. Playing with this.
Hold on to that.
Yeah.
It's a one little box is for 0.04 is one little box. Yeah, and that's time, that's seconds. And that is just the big box. The big boxes. Everybody have one? Yeah. All right. The big boxes, so the heavy pink lines, that's 0.20. So as the paper comes out, the speed is 25 millimeters. 25 millimeters. No. Yeah. So that's what we use in the United States. Sometimes in Europe they use 50, but we use 25.
Before we get back to the speed, does anybody have a trick for how long, like, if you want to calculate the rate of somebody's EKG, what your trick is? Yes, that's what I use too. Does everybody know that trick? No. Okay. So on your solid lines, the darker pink lines,
I had I'm giving my person ASIC already. Jeez. You know, same number for you. That was both ASICs. So they have. Okay, so if you count between ours, how many big pink boxes or like dark pink lines? It's like 300, 150, 100. And then if you keep going, it's 75, 60, 50, 50. And then, I don't know. By that point, if I don't know it, I just look at the top. Yeah, then it gets into half piece, and then I just look at the top, honestly, and see what it calculates through to. So that's one way.
Count from R to R.
I count from R to R.
Then I turn by R to R.
Oh, yeah. Yeah. The other way to do it is if you have a 6-second rhythm strip, right? If you know that this is 6 seconds in total, you have this many beats and that. And I know that this is 6 seconds. I can count how many beats I have and multiply it by 10. Does that make sense? Everybody got that? So I have 1, 2, 3, 4. 4 beats over the course of 6 seconds. Which gives me a heart rate of 40. Make sense? If I have a rhythm strip that I know is 6 seconds long, I count how many beats I see in that 6 seconds, and then multiply by 10 to get beats per minute, right? 6 times 10 is 60, 60 seconds per minute. So if I have 4 beats over the course of 6 seconds, times 10 to get minutes, I have 40 beats per minute. Make sense? I can also do the same thing if I have a 10-second rhythm strip. If I know that this is 10 seconds, and I have 3 beats in that 10 seconds, what do I need to multiply by? Yeah. Then I have 36 beats per minute. Oh yeah. Whatever. 26. That's 18. It is. This is why I use MD-Calc. Which, like, let's hope your patient doesn't have that, but...
Alright, so, how do you know you have a 6-second strip? There's a way to figure it out. Because you have your paper, you've got your big, the pink lines, the bold pink lines are 0.20 seconds each. So how many of those do you need to have 6 seconds? 30. You need to have 30 of the heavier pink lines, and that's your 6 seconds.
It's so much easier.
Right, I agree. Yeah.
I will say in the hospital it's a little bit easier because the printout of an EKG is always 10 seconds. Like the script that we get on phone is always 10 seconds.
I mean, you print out probably when you're doing it on clients and she wanted she's doing that. So she thinks it's right every time.
The problem with 12 leads is that it's not 6 seconds for each piece that they do, and it's not monitors. So,
Separate 6 seconds.
yeah,
Separate time frames for each.
right. So,
It's like, what's the cleanest and then prints out?
yeah.
So they're not, so what shows up in B2 is not the same time frame as YouTube.
Yes, so if you want to count the rates, print it out and read it. Okay? So, print out your 6-second strip and then you can count it. Got it. If you're doing it by the method that Janet did the French way, the 300, 150, 175, you can do that on your own. What's the key? Is our monitors are mostly exempted? So this is French?
It's just a screenshot we disconnected because I'm too far.
So,
Makes sense?
So it's just a screenshot.
Not yet.
So, that answers your question about how the next department. If you put it, if you put it on the front, it doesn't matter. It's just usually it's just right there.
Somebody somewhere at one point decided that lead 2 was going to be people with them strips, and nobody really questioned it. That's kind of it. I wish there was a better answer, like a scientific reason why we chose lead 2. There's not. I personally use the 300, 150, 100. I find that so much easier. Right? Yeah, it's so much easier.
Yeah, I've done that all that, so.
Yeah. And I love math,
I hate that.
but it's easier in the moment, especially when you need to figure out these things quickly.
So if it's,
Okay.
on here, on here,
Makes sense? We're getting there.
We're going to practice a lot.
Well, yeah. This is all just so that you have seen it once before you like go into looking at the squiggles. So back to the integral things and your question about isn't this supposed to be, what did you say, less than 0.2, right? So that's the PR. The PR is supposed to be normal is 0.12 to 0.20 seconds for a PR interval. That's the normal time, that it takes for atrial depolarization and contraction. Yes.
And you measure it from the beginning of the P wave to the beginning